All right, so we're excited. We're working on a revised version of the diabetes guideline. So I think this will be the third iteration. It is to the test of time. It's one of our popular guidelines, but we all recognize that things are changing in diabetes. A lot more therapeutic agents are available. Indications for drugs that we have used up till now have changed. There's a greater emphasis on cardiac and renal protection, seeing that those are some of the main complications that patients with diabetes suffer from. And we're also looking to make this guideline a little bit more user-friendly. By that, I mean directing the clinician in a little bit more structured manner on when to use what drug, how you select a patient that's suitable, when a particular combination is appropriate. How do you assess a patient with multiple complications and, let's say, different stages of frailty and debility? What is appropriate for each patient? I think they'll again be more familiar with the goals of control for older adults, which are a little less stringent than younger adults. So we'll reinforce that. We will be able to guide them better to de-intensify and simplify the regimens. Diabetes treatment regimens have got inordinately complex. Patients may easily be on 2 or 3 oral agents and 2 forms of insulin and glucose like peptide 1 agonists, which are all also injectable treatments, barring one, which is oral. So the thinking now in diabetes has changed in that we need to focus on simplifying treatment to match the needs of older adults. What can they handle? What is their diabetes burden? What level of diabetes distress do they feel? And what is their support system? So we want to match treatment to that capability. And we also want to de-intensify treatment to really reduce the risk of complications, reduce the burden of treatment. And particularly in the nursing home, for instance, we are going to aim to try to reduce the number of glucose checks for those people who are on more simpler forms of treatment. So part of it depends on the setting and the type of patient you're treating. Not every older adult is the same. So I tend to look at older adults in this way. How long have they had diabetes? I make sure I know if it's type 1 or type 2, because type 1, they're absolutely dependent on insulin. So that's a number 1 priority. So I decide, do they have type 1, type 2? What kind of setting am I treating them in? Are they in a nursing home with full support of nursing? Or are they in an assisted living center where you might have a basic license where they can't even do glucose checks, and a home health care nurse or another health professional has to do glucose checks? So you have to gauge your battles. What resources are available? How complex is the patient? And what exactly do they need? And then I try to look at them in terms of their complications. I look at them in terms of, how advanced are they along the course of their disease? For instance, if they have dementia or a heart attack, stroke, they're in renal failure or some degree of chronic kidney disease, then my goals of control are less stringent. So that's number 1. And I look at the support system as to how complex my regimen is going to be. So I try to give each patient something they can handle. Now, in the nursing home, we've worked on this with the American Diabetes Association. We have a very helpful position statement on diabetes in skilled nursing facilities. And we recognize, as skilled nursing facilities and long-term care, we recognize that even within our facilities, there are 3 distinct populations who we're managing with diabetes. One is the short stay patient who is there hopefully for rehab and has a potential to go home. So we have to tailor therapies to what is the support system at home. What can they manage? Then the second group is your long stay patient. And these patients often have dementia, they're functionally impaired, and need a lot of assistance. So their prognosis is generally poor. Control is going to be less stringent. We want to simplify treatment. We definitely want to reduce the risk of hypoglycemia. So we tailor treatments according to those priorities. And then the third group are the people who are at the end of life. So they may be receiving palliative care and symptom management, or they may be actively on hospice care. And so with those patients, the priority is to simplify the regimen, to reduce the intensity of treatment, the number of shots, the number of glucose checks, keep them hydrated, avoid hypoglycemia, and also try to avoid unplanned emergency room visits. But there's a lot of the important thing is to consult with the patient and family. What are their wishes at that point? Yes, we are looking at the previous guideline very carefully. Our goal is to make it shorter. I think it'll be more usable. We want to add a section on how to manage diabetes in assisted living facilities because, as I've indicated, the resources there are not the same. And the patient type may not be the same either. And then we want to add a section on technology because you may be familiar, diabetes technology is expanding by leaps and bounds. And at the very least, continuous glucose monitors are here to stay. That's not to say every long-term care patient may be suitable. Certainly people with type 1 diabetes, it's now generally recommended they should be on a continuous glucose monitor. So we want to talk about technology. We'll certainly have patients coming to our facilities with insulin pumps, and we want to be familiar with those. Rather than stop using them, we want to help them use those pumps. And of course, more advanced technologies are coming down the line, and they're already being used in the community, smart pens and insulin pumps, obviously, and using even software systems called closed loop systems, where the patient doesn't have to really decide on how much insulin they're getting. Their continuous monitor, speaks to the pump. And the aim also with the use of technology is to reduce the burden on the staff and to let us know when there is severe hypo or hyperglycemia, which in the past we wouldn't necessarily have known if a patient had atypical symptoms. You'd only know if you did a glucose check, and that's not always done when there's a change of condition. So emphasis towards safety, incorporating technology when it's appropriate, again, avoiding hypoglycemia as much as possible.